Good morning, afternoon, or evening, depending on where you're joining us from. My name is Wiswa Lizimazibugo from ICANN, and I want to welcome you all, those that are joining today in our webinar series 6, and we are in the final week, which is week 6. And I'd like to, would also like you to know that all participants that are attending at least 4 out of the 6 sessions are going to get the certificates. And for you to also get the certificate of attendance, you have to be able to stay on for at least 60 minutes. As you all know, our series is addressing IPC leadership and management. And today we are going to be looking and addressing the challenges and barriers in implementing IPC best practices. Please keep yourself on mute and the camera off, as this will assist us in enhancing the quality of the presentations. If you do have questions, please post them on the Q&A box, and we will address it after all the presentations have been done. And then please also note that we do not respond to raised hands. So if you have any questions, please direct them to the Q&A box. At this point of time, I would like to introduce Dr. Chika from the Africa CDC to give us an update on the status of COVID-19 in Africa. Dr. Chika, over to you. Thank you.
Thank you, Lizzie.
Dr. Chika, you are on mute.
Okay, yeah, sorry, I just wanted to make sure. Please, are you able to see my screen?
Yes, we can see your screen.
Okay, thank you very much, Lizzie, and good afternoon, everyone. So I'm going to take you through the epidemiological situation of COVID-19 as of 14th of April, 2021. So let me move to the next slide. It's taking time. I don't know why. Issue is from the system. It's actually not moving. Oh no.
Okay, meanwhile, whilst we are sorting out that technical glitch, maybe we can have our next presenter ready. And then after they have presented, we can always go back to Dr. Chika. At this point of time, I would like to introduce Mr. Jacob Nkwan-Kopt, who is from ICANN and is from Cameroon. He is the IPC focal person at the Cameroon Baptist Convention Health Center and is the Chair Ambassador for 2018 and a member of the IPC WASH Technical Working Group. Sorry. Dr. Chika, are you now ready?
Yes, it is better now. Thank you very much. So,
all right.
Let's proceed.
Okay.
Sorry for the glitch.
Apologies for that.
We will take beyond you back. Technical issue.
Okay. It's okay, Dr. Chika. Apologies for that. We'll take you back to Dr. Chika, and then thereafter we will introduce the next speaker. Thank you, and over.
I don't know why it is not moving. It was moving earlier and now it is not moving again. So, but let me just, while I continue presenting and hopefully the screen will Once I put it on a what's it called, viewer slide, it doesn't move. I don't know why that is like that. So, but let me quickly just say that so far globally, overall, there are over 136 million cases of COVID-19 that has been reported, and more than 2.9 million have died, resulting in a case fatality rate of 2.2%, and Africa accounts for 3.2% amongst other regions. Americas and Europe is reporting the highest. It's not moving. I don't know. Can you share if you have it on your side? Let me stop sharing.
No. I'm saying put your cursor on the screen and then click and then start just scrolling.
Okay. Thank you.
Yes.
Thank you very much. Thank you. Okay, so let me begin. That this slide shows the epidemiological situation of COVID-19 as of this day, as of yesterday, 13th April, as the global update is usually captured a day before today from the WHO platform. So the word on the left shows the distribution of reported COVID-19 cases by country, and 22 countries, including South Africa, which have reported more than 1 million cases, and countries are indicated by the darker blue color. So these countries reported over like 79% of all the cases globally. So the epic curve on the right shows the new cases of COVID-19 reported daily by WHO region, like I said earlier. Then currently there is an upward trend in cases from the Southeast Asia, European, and the Americas. Africa in red accounts for 3.2, like I said before. So far, over 136 million confirmed cases, 2.9 million deaths, and resulted into a case fatality rate of 2.2%. So moving on to the EPID curve on the slide shows the trend of new COVID-19 cases reported daily by the AU member states from February to date. And the EPID chart is showing the number of new cases. The y-axis reported by day, x-axis, the 7-day moving average represented by the red line is showing a downward trend in the number of new cases reported daily in the past week. So, however, this varies by regions, and the eastern region in red and the northern region in gold are experiencing upward trends in new cases. Cumulatively, over 4.3 million cases have been reported, over 116,000 deaths, resulting to a case fatality rate of 2.7%. Is higher than the global CFR, and 90% have recovered in the continent. So this table is showing the distribution of new COVID-19 cases and the deaths and recoveries by AU member states. As of today, 9 a.m., over 5,000 new cases has been reported, 164 new deaths, and over 5,000 new recoveries have been reported from 53 member states. The eastern and the northern regions accounts for 66% of the new cases reported, and the eastern region reported the highest new number of cases, while the southern reported the highest new deaths this day. It is majorly influenced by the number of deaths reported from South Africa. Okay, so Ethiopia, Tunisia, Kenya, South Africa, Libya, and Egypt accounts for about 63% of the new cases reported in the continent. So here is the slide. This slide is showing the distribution of new COVID-19 cases reported per 1 million population per day by AU member states across the continent. And we have grouped the incidents into 5 categories. In the past week, 24 countries reported less than 5 new cases per day, and 19 countries reported between 5 and 15 new cases per day. 3 countries reported between 50 and 100 new cases per day, and while 4 countries are reporting more than 100 new cases per 1 million population per day. So this week, we do not have information for 5 member states. So next is showing the COVID-19 case fatality rate by AU member states, and there are 5 categories. 8 countries have a case fatality rate that is less than or equal to 1. 25 countries have a CFR that is between 1 and 2.2%. 18 countries have a CFR that is between 2.2 and 5%, while 3 countries have a CFR greater than 5%, and these are Sahrawi Republic, Sudan, Egypt, and other countries, but we do not have current information for one country. So in terms of testing conducted, the chart is showing the trend of testing in Africa from February till this day, whereby more than 41.7 million tests have been conducted across the continent, giving a test per case ratio of 9.5, which is below the WHO recommendation that ranges between 10 to 30 tests per reported case. And it gives a positivity rate of 10.4%. The chart on this slide shows the number of new COVID tests shown in gold bars, and the cases are in red bars. So on the left y-axis, as well as the test positivity shown by the black line on the right axis by epidemiological week. And the test positivity is showing a downward trend overall. However, it shows an upward trend for the last week, which is week 14 that we are now. So finally, the map on this slide is showing the variation in test positivity across 55 member states for the past epidemiological week. And 9 countries have test positivity less than 2%. 14 countries have test positivity between 2 to 7%. 4 countries had test positivity above 7 to 10%, and 14 countries have a test positivity greater than 10%. Out of the 14 countries, out of the 55 member states, 14 countries with no available information. Once again, I apologize for the initial hitch, and I'm available for any question. Over to you, Lizzie. Thank you.
Thank you, Dr. Chika, for that informative update so that we as a continent can get to know the status of the preparedness and the response when it comes to COVID-19. Thank you so much for that. And now I'm going to introduce our next speaker, who is Mr. Jacob Nkwan Kopt. He is from Cameroon, and he works at the Cameroon Baptist Convention Health Services and is the Chair Ambassador for WASH for the year 2018. He is also a member of the WASH Technical Working Group. Jacob is going to walk us through the Cameroon experience on the challenges and barriers in implementing IPC best practices. Over to you, Jacob. Thank you.
Thank you, Lizzie. Can everyone hear me?
Yes, we can hear you.
Yes,
okay. Good morning, good afternoon, and good evening to everyone, depending on your region. As the coordinator already said, I will be discussing the Cameroon experience of challenges and barriers in starting and implementing IPC program. We will begin with an introduction. We will look at the background of the CDC Health Services, I will go to challenges. We'll talk about solutions, what we did, and then we will talk about lessons learned, and then we will come to the conclusion. Before I continue, during the Ebola outbreak in 2014 in the West African region, a lot of countries initiated IPC programs, and I don't know which countries still have functional IPC programs in West Africa, and I don't even know how many countries in Africa have functional IPC programs. But what is very clear is that IPC is looked upon as part of outbreak response activity, rather than a strategy to improve the quality of care. And so most of the time, most countries will wait for an outbreak before they can put IPC on their agenda, which is not supposed to be the case. IPC generally is one of the 8 core components of, IPC program is one of the 8 core components of the IPC WASH as proposed by the World Health Organization many years ago. And when we talk about IPC program, we are talking about the IPC team and the IPC committee. And the IPC team can also be structured in different ways in different countries. In some places, they have introduced the Link Nurse program, which is part of the IPC team in addition to the IPC nurse. And then the IPC committee now is responsible for reviewing policy and recommending strategies and the guidelines to improve IPC in the facility or in the region as well as in the country. And according to WHO, IPC program is supposed to be available at the facility level, at the district level, and at the national levels. There is a statement which Wenzel and others made in 1998, that's more than 20 years ago, which I found it very, very important and useful to today's discussion. They said the quality of hospital or health center IPC program is a reflection of the overall standard of care in that institution, meaning that where the IPC program does not exist, then any kind of care that is offered will be of doubtful quality. And therefore, for us to guarantee safe and quality health care, then we must always consider IPC WASH. Why do we even have to have IPC WASH in the first place? There are actually a global movement and global problems that makes IPC to be more relevant today than it has ever been in the past. Some years back, WHO started the initiative of universal health coverage, and we are also aware that the patient safety movement is also taking center stage at the WHO agenda now. We are also aware that antimicrobial resistance is becoming a very serious problem across the globe, and the healthcare associated infections is also very common. And specifically for developing countries, we have outbreaks, multiple outbreaks, and all of this problem, we have one solution, and that one solution is IPC. And therefore, IPC is no longer something that we could just talk about, but it is something each facility must consider. And recently, with the COVID-19 outbreak, we are all aware that even non-health facilities have understood the importance of IPC WASH, and almost every country and every facility, they are beginning to discuss IPC. And the African region as a whole, there is also a movement to institutionalize IPC in the continent. There is a statement to my right, which the Minister of Public Health in Cameroon issued about 2 months ago, which is very, very relevant. He said it has been observed that during the current times, we are experiencing some great challenges within our working environment, especially in our health facilities. One of these is with relation to health professionals' capabilities to minimize and prevent contamination and infection within their working environment for the safety of users and professionals. To this effect, I urge health facilities managers, both public and private, to put in place an infection prevention and control committee with follow-up. Now, with follow-up and reports of activities on a monthly basis. In Cameroon, this is the first national movement to begin IPC in the country. Even though IPC had existed at the level of programs, but it has not yet been institutionalized. And so we don't have national, district, as well as facility IPC programs, apart from private initiatives like that of the CDC Health Services. So I see this statement from the Minister of Public Health, which is part of the response to COVID-19, as a step forward towards promoting IPC in the country. And I believe that other countries have taken similar initiatives. I will now talk about the CDC Health Services. The CDC Health Services is a network of health facilities run by the Cameroon Baptist Convention Health Services. It's actually a faith-based health organization. And then we have about 100 health facilities spread in 8 of the 10 regions in Cameroon. The health facility, they range from small health centers or health posts, which is at the very remote areas, and then small hospitals and big hospitals in semi and the urban areas. And every year, we see between 1 million and 1.2 patients per year. I will also talk about how the IPC program started in the CDC Health Services. Actually, that was in 2002, and that was 2 years after an audit was done in our facility where I was working at that time. And then the audit indicated that the quality of care was declining as a result of absence of IPC. And that audit was done by a volunteer midwife from the US, and that was in 2000. And then 2 years later, in response to that recommendation from the audit, the IPC program was started in two of our 5 hospitals that existed at that time. And one was in Banso Baptist Hospital, where I was working, and then Bingo Baptist Hospital, which is in the same region but further away. And we had the first planning meeting on the 17th of May 2002, in which the IPC nurse was appointed, and then the IPC committee was created. And we also laid down guidelines and procedures on how the IPC nurse and the committees were going to function. There were many challenges at that time, but I want to highlight only a few. The first thing is that at the time we started IPC in 2002, the concept was relatively new to almost all the staff, even including members of management. And so people did not really understand what it was all about. And to work in that kind of environment, which people don't really understand what you are talking about, was going to be very difficult. The second thing is that we did not have trained IPC watch personnel. I was appointed to head the IPC program, but I was not trained at that time. I just graduated from the nursing training, and I was asked to take up the responsibility. In addition, we also did not have guidelines. And then we also had limited supplies and budget. So most of the things that have to do with supplies and budget was very difficult. We all know how health facilities in developing countries struggle to meet their needs in terms of supplies and finances. And then the next thing is that the environment at that time was also a little bit hostile. There were people who did not even want to hear anything infection prevention. And personally, people refer to me as somebody who was idling around, looking for what people have not done in order to talk about it. And sometimes they actually nicknamed me infection. They were calling me infection. I mean, just to kind of cause people to know that the program was not even relevant at that time. And then the last problem we had was that behavior change, as we all know, is a very difficult and challenging thing. And so sometimes it is usually very difficult to come by. After some time, a lot of people that were rejecting the concept at that time, about 3 or 6 years later, some of them came back to me and told me that they were actually doing so in ignorance. So Where people are not aware of anything, then sometimes to change their attitude becomes very, very difficult. How do we manage to overcome the problems? There were three very key important things that we did. The first one was networking and collaboration. The second one was training, education, and promotion. And then the third strategy to overcome the challenges was creativity. We are going to discuss each of these strategies in more detail. Let's begin with networking and collaboration. As early as 2003, we worked with the International Federation of Infection Control, and 70 copies of the basic concept. That's an IPC textbook that was developed and published by IFIC. 70 copies were donated to us at that time. I really thank the initiative of Patricia Lynch, who was the chairperson of IFIC at that time. And then we also had some collaboration with Association of Professionals in Infection Prevention and Control, that is EPIC. In 2003, they donated some manuals and guidelines to us, which we use to begin our program. And then the next networking and collaboration was with the Action for West African Region. That is an NGO that was promoting, responsible for implementing PMTCT program in West Africa at that time, and IPC was one of the components. So they funded some IPC seminars between 2006 and 2014, which were done across the country. So we train, they actually train trainers, and then the trainers now roll out the training to different facilities. And I think this training was actually a turning point in IPC program in the country, because what people did not know, as soon as they understood, they became kind of a part of the implementing team. And then the next partnership was with Infection Prevention and Control Association of Canada, IPAC, and that was in 2011. We had a twinning project with them, and which was what was involved was that they were donating medical supplies, textbooks, and journals to us. And then two of their members also visited in 2012 and then evaluated our facilities in order to identify the needs. And then when they went back now, they mobilized the rest of the team, and then they were collecting supplies and donating to us. And some of the donations were actually IPC textbooks and journals, which helped us to understand exactly what IPC was all about. And then the last networking and collaboration was between CDC Health Services and Infection Control Africa Network. We started in 2016 up to date. There is a lot that we have done with ICANN, which I will not be able to list all of them. So what I'm actually saying about network and collaboration is that you may have a problem, but there is somebody somewhere who already has the solution. And so you need to work with people. They will be able to provide the solution to the problems that we need. The second strategy was training, education, and promotion. From 2003, we conducted a series of seminars and workshops for staff, facility managers, and then special departments like the dental services. And when we did the training, one of the key areas that really kind of understood the concepts and they significantly improved IPC was the dental services. There were two dentists at the time, and they really bought the idea wholeheartedly. And they were now responsible for spreading for pollinating the rest of the dental departments with the IPC knowledge and concepts. And then beginning, especially from 2017, when we were doing some work rollout, we decided to engage in public sensitization about IPC concepts. And we did training, and then we went out to facilities, and all the facility leaders, they signed commitments to implement. Actually, we were using hand hygiene as the entry point, but we're actually involving IPC as a whole. So all the facility leaders, they signed a commitment to implement hand hygiene in their facilities. and by implication also IPC in general. So this public demonstration and sensitization also caused people to know that IPC was important, and it also improved the acceptance of the program across the system. Then the last strategy was creativity. There was a statement Professor Sade made last week, which I would like to highlight again. She said 80% of what we need to do in IPC, which is at the basic level, does not require finances, and that we only need finances when we are going to advanced level. And I think this statement is very true and very applicable, and I can share from my own personal experience. We need to be creative, we need to be innovative, to look at local solutions to local problems. It will always think that things will come from elsewhere. You might not have them all the time, but you have something that you can use in order to overcome the problems. So the first thing is that we adopted the strategy of using local material and resources. And as early as 2003, we introduced alcohol-based hand rub, as you will see on this picture in the middle. We actually prepared at the level of the facility. That was in Basel Baptist Hospital, and that was part of the response for the neonatal sepsis outbreak in the unit. So when we evaluated and we discovered that hand hygiene was poor due to lack of hand washing facilities or hand hygiene facilities, we decided to introduce hand rub, which we were producing locally and using in the unit. And later on, the initiative now spread to the rest of the unit in the hospital, and presently, alcohol-based hand rub is already used in the entire system. We have different dispensing system. We have the 5 liters we dispense to the facilities, and in the facilities, they will either use 500 mils, which might be on work surfaces, or 100 mils, which will be on star pockets, or 1 liter, which might be in the unit, or you might have this dispenser that are at the bedside. Then the next thing we also did is that we fabricated portable hand wash stations like this one you see on my right. That is a 2-level stand with a 5 liter or more bucket at the top and a receiver below. So when you open the tap here, as you are washing, you are receiving the water here. And then after that, you can collect the waste and empty. And the advantage of this one is that you can move it to any section of the unit where it is most needed. It's portable and it can be moved around the unit. So what are some of the achievements or the successes we have recorded? The first thing is that IPC wash is very, very acceptable in our facility now, and almost everybody already knows that it is important. Then the next thing is that I mentioned about the neonatal sepsis in BBH, that the outbreak was actually eliminated within 3 years. That was between 2003 and 2006. And then the next success, which is very key to us, is that we started producing alcohol-based hand rub locally, and we are now using it across the entire system. And the last year, that is 2020, we introduced alcohol-based hand rub by bedside, that is at the point of care in Basel Baptist Hospital. And it's a pilot project which we are also going to explore the possibilities of scaling it up to other facilities. And lastly, we've also had international exposures and awards resulting from the work that we have done within our setting. These are some of the awards that we have received. The Nurses in the Limelight, which was in 2012, International Ambassador Award from SHARE, that was 2018, and then Heroes in Infection Prevention and Control, that was in 2019, offered by EPIC. So, what is the leadership response or organizational support? Generally speaking, it took a lot of time for leadership to really buy into the concept, to the initiative. Even though they created the program, when the program started functioning, they were really not supportive enough. And until when we started making strides, especially when we started getting international support, it was then that they discovered that IPC was really very important. And we actually had maximum support from 2017, as I said, when we initiated the strategy of having leaders sign commitment to implement hand hygiene, as well as IPC wash in the entire system. So, and within that context, we also did public sensitization. And it was from there that the chief executive officer issued a circular instructing all the leaders of the facility to ensure that IPC is functional in all their facilities. And then there was also a statement that was included in our policy document because our vision is quality healthcare to all. And accompanying that vision, the statement says quality healthcare begins with IPC. So this kind of initiative and movement indicate that management is totally in support of IPC now. But we need to note that it doesn't come automatically. Sometimes you have to lobby, you have to change strategy, you have to tell the story many times in a different way before they are able to understand and lend their support. So what are the reasons behind our success? And those are the lessons that I would like us to carry home today. The first thing is commitment and dedication is very, very important. You know, for those of us who have implemented IPC, you will know that sometimes you can even almost be rejected. And so if you give up, that is all, you will never win. So you have to be committed and ensure that you do everything what it takes in order to achieve what you want. Then the second thing is that you have to be persistent. Don't give up. If you give up, you will never win. So no matter how many times people will say they don't want to see you or they don't want to hear you, then don't give up. Because when you give up, that is all, it ends the story. And then the next reason for our success is creativity. As I said earlier, even though we might not have everything we need, but there is something you have that you can use, which is around you, that you can use to solve the problem. So look around you and see what you have and how you can make it useful or how you can make it to provide a solution to what you need. And then the last reason behind our success is networking. As I said, yes, problem will exist, but the problem you have, somebody has a solution somewhere. So when you network, you learn. And then when you learn, you improve. And then through the networking, people can also come to understand what your needs are, and they might be able to support you. I think these are the 4 very key important things that whoever is beginning an IPC program, you must always ensure that you take note of all of these strategies. Now to conclude, I think it is not more something that we can say again that IPC is important. I think everybody has become aware that, especially with the COVID-19 outbreak, or let me say Ebola outbreak and now COVID-19 outbreak, we all know that IPC is very, very important. And we should not wait for outbreaks in order to implement IPC, but if we implement IPC, we will prevent outbreaks. And even when an outbreak occurs, we still need IPC. So we need IPC all the time. So IPC is a solution to every outbreak that we have. We need IPC programs at the level of the facilities, we need it at the district level and at the national levels. And I'm very happy for what African CDC is already doing to institutionalize IPC in the continent. So there is a very, I am not sure that there is any strict formula that we can use in starting IPC, but however, there are requirements. But if you check across the globe how people started, you will discover that each person used a different approach. So whatever works best for you, you can make sure that you follow it. Thank you for your kind attention.
Thank you so much, Jacob, for that detailed presentation. I couldn't have even said it better than what you did. And for you getting to show us that it can be done and that there is no formula, and we have to adapt to our local settings. Our next presenter, I'm going to kindly ask Ms. Christiana Conte from the Sierra Leone Ministry of Health and Sanitation. She is a current IPC National Coordinator, and she's going to Sorry, Christiana, you are still muted. Hello, Christiana, you are still on mute.
Are you hearing me now? Hello?
Yes, now we can.
Great. I am Christiana Conte, the IPC National Coordinator in Sierra Leone. And I want to share our Sierra Leone experience in handling the COVID, IPC, our challenges and barriers in the implementation of IPC best practices. So the outline I will give a brief background of the IPC program. I will also want to share with you the structure, challenges, the lessons learned, and what is actually working currently in the country. Let me give you a quick overview of the Sierra Leone for those who don't actually have a clue about this country. It's a very small country on the west coast of Africa with a population of only 7 million. But then this small region is divided also. The country is divided into 4 regions. And we all know the capital city, which is Freetown. And with our health system, we have 29 government hospitals. And we have 1,300, pardon?
Sorry, Christiana, there's echo behind, like when you speak, something else is speaking.
Yeah, okay. I've asked them to just reduce their volume. The volume is still high. Is that okay? Are you now clear? Are you getting me clear?
Yes. They can just wear earphones.
It's not better.
Yes, thank you.
Okay then, yeah, good. Let's proceed. Oh, the next slide is not going. Good. So a short background on the IPC program. We are all aware in 2014, 2015, we had an Ebola outbreak in Sierra Leone and in the West region, in which we had over 8,000 infections, and we had a very high number of healthcare workers who were infected. So assessment done during that 2014, 2015 actually highlighted vulnerabilities in IPC. So in 2015, the IPC program was established. From all of the lessons that we learned, there was huge healthcare associated facilities. So this program was established in national units that was established, have IPC units also established, public hospitals across all the 16 districts. And in each of these hospitals, we have trained IPC focal persons. In addition to that, we also have IPC supervisors trained in all of these 16 districts. In addition, we identified IPC link nurses and in some departments, of course, personnel to support the IPC focal person in each of these hospitals. And also we have in our primary healthcare facilities, we also identify these IPC link personnel who actually work directly with the district supervisors. All of these people from the IPC teams that we now have established in the hospitals, in all of the districts and even at the PHU levels. We all know infection prevention and control is a scientific approach and practical solutions to prevent harm. And these, they involve standards and procedures. Also materials, we need a human resource if we are really to break that chain of transmission. As you can see on the other side of the slide, you can actually see the graphics there showing the multiple links and all the points at which the health system, of course, the healthcare workers, the patients themselves and their families, all of these people need to intervene to stop the spread of infection in the facilities. So why is IPC important for COVID-19 and even the EVD? Today, as you might have heard, we are at the height of preparedness because the neighboring country, Guinea, has recorded Ebola cases. And as we border with this country, we've heightened up our IPC preparedness. So why is it important for IPC? We want to minimize disease transmission to patients as well as the healthcare workers. So implementing IPC measures, we actually break this chain of transmission. We also want to identify persons with signs and symptoms of suspected COVID-19 and even Ebola for rapid isolation and triage. Because when you identify and you remove the source from amongst the rest, then of course, you are breaking that chain of transmission. At the same time, we want to maintain essential health services because from lessons we learned previously with the 2014-2015 outbreak, there was a huge interruption in the essential services wherein patients abandoned the healthcare facilities, afraid of contracting Ebola. So we never wanted we don't want this to repeat itself again. So another key component that we should be looking at is to maintain the essential services as well as responding to the outbreak. So the strategies and priorities that we actually set at healthcare facilities. And we all know IPC should be focused on priority activities. Why? Because we are aiming to stop the spread of any outbreak within our healthcare facilities. So we are looking at triaging of sick patients because that's the first contact of a patient to a healthcare facility. If we triage, we can easily identify the sick. And then of course, when you identify them, you definitely remove them and then you keep them in an isolation. We also want to manage the visitors that are coming into these healthcare facilities, especially when we are in an outbreak. We also want to manage the exposed healthcare workers because if we have a huge infection rate among our healthcare workers, what happens? The patients out there have no more confidence in the health system and all of them will avoid accessing the healthcare facility. So we need to manage the exposed healthcare workers. We also need to establish a standard IPC system. It has to work because if measures and standards are not maintained, particularly during an outbreak, then you can imagine the rapid spread of this infection in that healthcare facility. And that goes beyond, in fact, because we have huge amount of visitors who do come and loved ones who are coming to this facility. So that means our community transmission will be too huge. So we must establish systems, standards in the healthcare facilities. And also concentrating on emergency PPE strategies, because that's another big issue. We need the supplies for a proper, effective IPC implementation, particularly during outbreaks. We need the supplies, and we also need a real strategy in the supply chain so that these supplies will never dry, will never run short in the facilities while healthcare workers are actually providing care for their patients. So at the level of implementation, when IPC standards and measures are correctly implemented, we can actually reduce the transmission of COVID in healthcare facilities as well as the communities. Because if we do put in place all of our strategies in the healthcare facilities, we can actually minimize the transmission rate, healthcare associated infections in the facilities. We can also enhance the safety of healthcare workers, the patients, our networks, and also the communities out there, and also enhance the ability of the healthcare facility to respond to the COVID-19. So implementing IPC standards and measures is very, very key at all times. In fact, not only during outbreaks when we are responding, but it must be in place at all times in the healthcare facilities. Now we look at the barriers. Having said all what it takes, the importance of infection control measures, yet there are still barriers in the implementation of these IPC measures. The first we can think of is WASH, and of course the infrastructure gaps. You cannot implement IPC without water, which is the basic. What about the hygiene? And we also look at our infrastructure. Some of the facilities, the structure of the facility, the design, if you look at it, it's so small for the catchment population that they are serving. So all of these will actually encourage overcrowding and it becomes very difficult. So that's one big barrier for the implementation of IPC measures. We also want to look at the inadequate funding. IPC, of course, there are lots of activities that needs to be implemented. And even when you look at IPC consumables, these are things that you need to replenish. But then if you don't have funding, all of these activities will never be implemented. We also look at the gap between the policy and the actual implementation. On the policy, they will state it is established, but then you are looking at the implementation out there. What about the support? The support from the leadership, the support in terms of supplies, the support in terms of funding in general. There's a huge gap. That's another barrier in the full implementation of IPC. Limited laboratory support and surveillance systems. In a low income country where we don't have established microbiology labs, it becomes so difficult when you want to actually set up IPC surveillance on healthcare associated infections. That's another big barrier in the implementation of IPC. We also look at the limited human resources. In our settings, normally we have a huge volunteers in the healthcare facilities. So if you invest a lot in these volunteers and eventually they leave, it becomes another huge issue. And in areas where you don't even have the volunteers, it becomes so difficult with the few human resources that you have, with the dual services that they have, meeting all the demands from all of the programs, it becomes another huge barrier in the full implementation of the IPC activities. We want to look at the supplies. IPC we deal with a lot of consumables. We need them, you need to replenish them. Procurement issues. It takes a long time for you, even when you procure, for you to get some of these commodities. All of these will actually hinders on the implementation of IPC in the facilities. Another most important area is the political buy-in. If you don't have the support of the leadership, if the political leaders do not appreciate the importance of infection control, it becomes very difficult for its implementation at the facility levels. Lack of role models, people standing out there to support the IPC programs, being role models, all of this, because I can imagine if you are in a healthcare facility and the management, the senior top management of that facility comes in every morning, performs the hand hygiene correctly before moving into their offices, that sends a signal out there so that everybody else walking into that facility, it's a must for you to perform hand hygiene because that's the leadership who is a model for you. And we also look at the culture. You know, in Africa and in some of our regions, the cultural beliefs is another issue for us in implementing full IPC measures. And in addition to all of this, imagine in Africa, we are here struggling with endemic diseases. One great killer is the malaria program. Malaria is a great killer in our sub-region. So with all of these diseases coupled together, where programs are set up, funding is being deviated, a lot of attention is being paid to some of these diseases. Little attention normally is being paid to infection control, which people are really forgetting that infection control is the foundation of quality of care in a facility. The major challenges we are faced with here, having gone through some of those barriers, our major challenge today in Sierra Leone in the implementation of our IPC program is inadequate water, sanitation, and hygiene infrastructure, the WASH, in our healthcare facilities. It is actually compromising the IPC compliance. If you want to look at the patient flow, the space, water, incinerators, broken incinerators. We don't have sinks out there designated for hand hygiene. We have to improvise with Veronica buckets. So this is a big challenge with these Veronica buckets that we are using. Of course, they are breakables. We need to replace them from time to time. So we actually need that budget for you to be able to replace all of these broken things. Another major challenge we are facing, non-availability of well-equipped triage station at the entrance of our healthcare facilities. And from the lessons we learned during the Ebola, it was one of the great impacts really on the huge number of infections. Because if we don't have a well-equipped triage.
Is this mine? Oh, God bless you.
At the entrance of the healthcare facilities, then it becomes very difficult for you to easily identify and source control of any infection coming into a facility. Another big challenge we have is lack of high level of clinical suspicion. Yes, people are trained, they're out there working in the screening areas, but then that high level of suspicion so that we can easily identify the cases as they do come to these facilities. And another huge challenge that we're faced with from the lessons we've learned, despite the knowledge in IPC, we are still finding difficulty in maintaining standards due to lack of resources. Because we need funding for us to be able to set up the IPC program effectively. So the resources is one major difficulty for us. Another one is the misunderstanding of guidelines on PPE use. You know, because of fear during the 2014-2015, despite all the trainings that you give healthcare workers, because of fear, you know, people always use the PPEs as though, you know, they are protecting themselves, even though, you know, there are differences between PPEs we use during Ebola, during COVID, and all other diseases. But then that's a huge problem that we do have now as a result of fear and panic. Then also during the COVID-19, what we actually experienced, people are still reflecting back on 2014, 2015. And so we had that huge fear and panic, wherein people resulted in fumigations, you know, closure of facilities because you have few healthcare workers who are infected from that facility, all as a result of the experiences we had from the 2014-2015 Ebola outbreak. Another major challenge is the inadequate PPE for healthcare workers across the country. You know, when every country was actually struggling with a pandemic, we have little sorts of support from PPE stock coming into the country. So we had a very, that's very challenging for us. We don't have adequate supplies of PPEs in all of the healthcare facilities. I've made mention about the dedicated funds for IPC activities. We've still not been able to have dedicated funds set aside for IPC activities. And another most important challenge, which is very, very difficult for us, is the inertia on behavior change among our healthcare workers. The knowledge is there, but just for them to adapt, let every one of them have that culture of safety. It's a very big challenge as of now in the country. So our successes in the IPC program so far largely depends on these few strategies that I will discuss. The Ministry of Health and Sanitation promoting a spirit of ownership of IPC programs at all levels. That has actually led the success of IPC implementation since 2015 to date. We're really having, you know, the leadership, they show a lot of support, but then we are still struggling with the budget, you know. The managers are also taking lead and coordinating the IPC activities with the support of our partners, because we do have partners in all of our districts, in all of our regions, who are actually supporting the district management teams, and some of them are supporting the hospitals. And so the managers are actually coordinating some of these IPC activities. Another success story is promoting expertise to support development of IPC programs at all levels of the healthcare and building on what is already achieved in the country. And we have even gone further to train IPC specialists. We've had 2 cohorts train IPC specialists. So we are actually developing that human capacity so that we have IPC experts in all of our districts to support the IPC program. We also have a strong collaboration with other stakeholders and development partners. You know, we have a very strong partner mapping so that we know exactly who is working where, in what district, and the type of support you are giving, so that we build on all of our strengths together, making sure IPC program is fully implemented in all of the healthcare facilities. And as a country, we've also promoted the public-private partnership to leverage extra resources in support of IPC activities. And the public-private partnership have also really supported. We've now brought on board all of the private hospitals that we do have in the country, and making sure all of them establish IPC programs in their facilities.
Apologies, Christiana, sorry. May you please round up? We've gone past the recommended time. Apologies.
Yeah, this is one more slide. Yeah. So what is working well? Implementing our IPC program in line with the WHO multimodal strategy. The system change. We are fixing up the system. So for the infrastructure, we are having refurbishment of some of the healthcare facilities. Some isolation units are being built in all of our hospitals today. We do have isolation structures. Supplies, we have, as a country, locally produced alcohol-based hand rub and soap to support hand hygiene in all of our facilities, and also partner coordination. For training and education, we have today established a standard training package, and orientation, refresher trainings, mentorship, and on-job training are ongoing. Of course, we have established, developed guidelines, SOPs, and job aids. And for evaluation and feedback, we have a regular IPC monitoring of healthcare facilities, the treatment centers, community care centers, and even the schools. We are monitoring at all times. So in summary, IPC is very important. So IPC is essential. It's an essential part of our healthcare service delivery. I always say it's the foundation, the basis on all care that we give. Management has responsibility to ensure policies and protocols are implemented. And of course, national structures are dependent upon full cooperation and commitment from the district as well as the hospital IPC team, and also as well as health delivery teams, both clinical and non-clinical, if IPC measures should be fully implemented. Thank you all for your time.
Thank you, Christiana, for that informative discussion and the take-home messages of ensuring that with IPC programs, there have to be a spirit of ownership. At this point of time, just to spice up also, in addition to what the presenters have said, we have invited a panel of experts from the various African countries. They've been involved in the Ebola outbreaks, and they are here to shed more insight on how the IPC programs have been sustained post the EVD outbreak. Please help me welcome Madam Fuller, the Chief Nursing and Midwifery Officer of the Ministry of Health, Sierra Leone, Dr. Teme, from the Medical Director of Last Mile Health in Liberia, also joined by Dr. Ben Grant, who is the technical lead of the IPC project for Last Mile Health in Liberia. We also have Nonhlanhla Ngwabi, who is an IPC specialist in the Medical and Research Institute in Doha, Qatar, and she has worked in the EVD response in Sierra Leone under WHO. And we have Maureen Kesande, who is the Senior Project Officer, IPC WASH at the Infectious Disease Institution in Makerere University, Uganda, and has also been involved in the EVD preparedness and response, and is also the Share Ambassador for 2021. Welcome, panelists. And without wasting so much time, I will just take you to the questions that I had for you. The first question is directed to Dr. Ben Grant. In your experience, what are the steps that health facilities or health systems usually go through to implement a program to improve IPC? Over to you, Dr. Ben Grant.
Thank you so much. Yeah, so our own experience in Liberia was the EVD in 2014 through 2015. Prior to that period, IPC was being practiced in the health facilities, but at a very limited scope, given that supplies were not even available in some instances, infrastructure was not really ideal and sufficient. And then when Ebola came, partners came by and provided those resources that were needed to combat the EVD pandemic then. Then now we have COVID. About several years later, that is post EVD. Practices in IPC have become non-existent in some instances. Practices were also, because of resources not available to facilities, were not being adequately observed. So measures for IPC were not in place. So our experience with the EVD response is to initially provide training to staff of health facilities, medical and non-medical staff at those facilities, and ensure also that supplies were put in place so that the measures for IPC are actually observed and practiced. So when that was done, we follow it with supervision and monitoring to ensure that the supplies were used for the intended purpose and that the measures put in place were sustained and health facilities staff did not get exposed or get infected with the COVID disease. And that went quite very well, that we can boast that the facilities that we manage under the Resolve project have very, very good results, that transmission among health workers is at zero. In those facilities, that measures in IPC have been increased, so much so that transmission among patients as well as health staff is also at zero. So that is the experience we've had. And what we're trying to ensure right now is institutionalization of IPC, ensuring that IPC becomes an integral part of clinical practice at all health facilities, that it does not just show to be a project that once it's over, then people tend to step aside from using it. So that is what we are pushing to achieve in this phase of our work in health facilities, where we work with 102 health facilities in 4 of the 15 counties in Liberia. Thank you. Over.
Thank you, Dr. Ben, for that. The next question is directed to Maureen. The question is, some of the initiatives to improve IPC last several months or maybe even a couple of years. For example, right now, IPC is getting more attention due to COVID-19. So when those short-term initiatives are over, how do you make sure that improvements to IPC practices are sustained? Over to you, Maureen.
Thank you very much, Lizzie. I take the opportunity to also congratulate Kwan and Christiana for the wonderful presentations. To answer your question, it is true that most of these interventions fade out, but one of the recommendations would be to embed IPC into the health system monitoring or monthly reporting. So when we look at IPC, we may select about 10 indicators that can be included in the national health monitoring systems so that these can be captured. This is one way to ensure that we keep track on the improvements that have come or the gains that we received during outbreaks. So I think it's a more sustainable way to ensure that this is ongoing. And the other thing would be to designate M&E personnel to support these IPC interventions and ensuring that this reporting is being captured and followed up with. Once we have that in place, we're able to develop quality improvement plans that are based on these indicators. And so you realize that if the indicators are not well monitored through a national system, then we cannot have robust quality improvement plans for IPC. So the two work together. If we have these in place, then the quality improvement plans can also come in to sustain the gains that we receive during, when the attention is stronger on IPC. Lastly, I would say I would probably, and I know Christiana talked about it in her presentation as well as Kwan, but leveraging on multi-level leadership. The role of strong leadership in achieving national and facility level objectives cannot be underestimated. So it's a recommendation to, look at strong leadership and at the same time have clarity of policies and guidelines at national level so that these can be cascaded to facility level in and outside an outbreak. So the policy cascade can only work, of course, if it is strong at national level, And this can be cascaded to facility level to further give strength to these capacities that have already been built. Thank you so much, Lizzie. Over to you.
Thank you, Maureen. And I'll direct the next question to Noor. You have been involved in IPC for many years. In your opinion, what traits or characteristics make leaders and managers successful in improving IPC practices? Over to you, Noor.
Hi, Lizzie, and thank you. So there are a lot of traits, I think, that can make managers successful in improving IPC practices, but I'll talk about the ones that I've observed and the ones that I think are pivotal. I do not think personally, that's my personal opinion, that leaders are naturally gifted with leadership skills, not all the leadership skills anyway. So some skills are acquired with time and some are acquired with practice, and of course some are acquired with experience as well. So I found that mostly with the outbreaks or my involvement in infection control, especially in the context of Africa, integrity is something that is very important in leaders. Leaders should lead by example. And as a leader, the best way to build credibility and gain respect is to have integrity and of course, leading by example as well. I've also found that emotional intelligence is very important. Cultural intelligence is also important as well. Because with outbreaks as well, you'd find that as a leader, you're put into a community that you're not really familiar with, but it is important as well to be considerate of the environment that you're in, which means you have to be culturally sensitive, culturally intelligent as well. Communication, of course, is very pivotal as well. This is one of the team steps components that is important because communication is a structured process by which information should be clearly and accurately exchanged among team members as well, and communication not only with team members, but also with the communities that are involved within that particular time when you do have an outbreak or you're involved in a pandemic, as we do have now with COVID-19 as well. So all the other qualities I think that leaders do have or should have are things that we do know as well, like being adaptable, being flexible, somebody who actually appreciates situations when they do evolve, more like the COVID-19 outbreak as well, which means you have to be well versed with what's going on. You have to be well versed with current evidence-based practices as well, so that you can be somebody who contributes wholesomely and also contributes in a way that also helps, I think, your team members as well. Thank you, Lizzie.
Thank you, Noor. And just one last question. May you please just round up your responses in just a minute, which is directed to Dr. Teme and Madam Fuller. What is the most important piece of advice you would give to a leader or manager who is just getting started in IPC? If you would just round up your responses in about a minute, and then we hand over to Dr. Iwande. Thank you. Dr. Teme first, and then Madam Fuller.
Okay, thank you so much for the opportunity, Lizzie. So basically, I have a couple of things that I would like to advise a new leader or manager just getting started in IPC. The first and foremost is to ensure that you have a sense of direction. You have a program with which you're working with at both national level, and then put some emphasis on supporting these different these different programs at subnational levels, including healthcare facilities. You should be a strong advocate for ensuring that there's a dedicated budget for the support of your activities, IPC activities. And then if you're like at the national level leading the program, for a new program, you want to focus on developing some guidelines that could be used to focus on education and training. And then defining policies, that will kind of strengthen your IPC stance within the country. And then one other area is to focus on monitoring audits activities. Good startup will be to use the WHO infection prevention control assessment tool. That will give you a picture of what your national program stands on an annual basis. And then you can also do this at healthcare facilities with the IPCAP, the infection prevention assessment framework. So those are all tools that can help you identify the problems you have and help you develop action plans that you can use to source funding to improve IPC programs at the different levels. So maybe one last thing, be focused with your approach on bridging IPC gaps because you cannot run all the essential IPC programs all at the same time. So maybe you're not ready for HAI surveillance, but you have to focus more on hand hygiene compliance, waste management, proper use of PPE, and the rest. So maybe I just like to, since we don't have time, turn it over to my colleague for the remaining of the time. Thank you.
Thank you very much. Okay. Go ahead.
Now it's over to you, Madam Fuller.
Thank you very much. I want to thank all the presenters for this meeting. All I have to say is that IPC is the backbone of healthcare delivery service in any part of the country, in the world. So therefore, as a new leader, you want to develop an IPC program, you have to have full knowledge of, first of all, of IPC, how it cuts across every fabric of the health system. And then you have to look for your partners. Who is interested in IPC? Who wants to work with you? You also have to conduct a baseline and see where the country is. How far are we with IPC? So that you can now develop your plan, a comprehensive work plan with your partners. And mind you also have to be in partnership with the Ministry of Health and Sanitation, who is the umbrella for healthcare delivery service in your community, in your country. So you as a leader, you must be selfless. You must love what you do and believe in it. If you don't, then you don't expect others to follow up. You also have to be a good team leader, not leaving anyone behind, ensuring that you share knowledge, skills, whatever you have with others within your team, so that wherever they go, they portray what you as the leader is interested in and want to achieve. You must have a goal. At the end of this year, what do I want to achieve in IPC in my country? So you have to work with others. You have to ensure that the leadership also in your ministry is interested. So therefore you advocate. You have to be a talkative wherever you go. In facilities, you have to pour out your belief in IPC and you have to give out examples so that people can see. You also have to pay attention to evaluation. At the end of every period, say at the end of this quarter, I want to evaluate what I have done and see my faults. And you always look beyond even your plan or even beyond your ministry to others. Like somebody said, there's somebody somewhere who can answer your questions. So I think these are the few advices that I will give to new leaders who are coming up if they want to succeed in implementing IPC programs.
Thank you so much, Madam Fuller. And apologies to Dr. Wande for encroaching so much on your time for the Q&A. Over to you, Dr. Wande.
Thank you very much. And thank you to all of our panelists. I think in summary, it's been a very good call to action, and we just have a few minutes. So I will take some of the questions. We'll do our best to take some of the questions, but I encourage the panelists to please type out some of the answers if possible. So Chika, there's some of the EPI questions for you, and they're around just an update on what the testing is. I see that you're typing your answers, so I think it will be helpful not to talk about that. So just one last question for you is the question around how we are supporting countries to enable testing and to ramp up testing. So if you want to talk a bit about how we're supporting the testing across member states. Over to you, Chika.
Okay, thank you, Dr. Wande. So about testing support, member states are encouraged by the RCCs, that is the Regional Collaboration Center. Africa CDC has like 5 of them in the region. So that is the hub where you can make your requests, and that request will be responded to through the RCCs. And also the laboratory team at Africa CDC has been supporting member states in terms of test kits, and distributions are ongoing in all member states who has made their requests known. So I want to use this opportunity to encourage member states who has or who is yet to, submit their request to be encouraged to send in their request to the RCCs, and their request will be responded to. So so far, Africa CDC has been supporting member states by distributing and sending test kits to the countries to encourage them to do more of testing, because obviously most countries are not adequately testing, and they need to reinforce their testing capacities. Over. And so far I have answered questions on the chats for those who have asked me questions. So I have managed to answer almost 90% of it. So, if you are not satisfied with my questions, please, I will drop my email address for us to continue from there. Over.
Fantastic. Thanks a lot, Chika. There's a question around, is Cameroon, is it only in Cameroon that IPC and WASH exist? And for countries that do not have existing IPC and WASH, how can we organize in connection with Africa CDC? So I just would like to reference something that Jacob already alluded to, is that we as Africa CDC and as Africa Union, we're really keen to support all of our 55 member states to ensure that at least their national IPC programs existing, and as such we have developed a legal framework that that is moving very quickly through the AU processes, such that member states are obliged or legally bound to at least have certain minimum standards that that can keep health care facilities safe. So that is what we are doing, but I'm certain that there are several other countries that that definitely have existing IPC and WASH facilities in place. I think one question that I see that Jacob already put a note that I was going to answer is, was neonatal sepsis eliminated only in CBC facilities or all over the country? If only in CBC facilities, when do you hope to roll out countrywide? So Jacob, if you want to answer that, and we can wrap it up. Thank you.
Thank you, Dr. Wande. Actually, my presentation is focusing only on CBC facilities. It's not a national program. And we actually eliminated neonatal sepsis in the Banso Baptist Hospital, where I was working as the IPC nurse at that time. And one of the strategies we used was to improve hand hygiene using hand rub. And that has been scaled up to all the facilities. So we can roll out the strategies and not the prevention of neonatal sepsis, because we will only target prevention of neonatal sepsis or control, whatever you can call it, when there is an outbreak. If there is no outbreak, but what we have seen that has worked, we just roll it out, and hand hygiene is already being rolled out to all the facilities of the CDC Health Services. And then recently, we are also piloting provision of hand rub at the bedside, that is at the point of care. And that is still in Basel Baptist Hospital, And as soon as we are able to roll it out to the rest of the facilities, we will also do so. So all the lessons learned in the prevention of neonatal sepsis have been rolled out to all the facilities, and we will continue to improve as the means become available. Thank you.
Okay, thanks so much, and thanks to all of our experts on this panel. Your questions have been noted, and as we always do, we would definitely document it. If you remember correctly, last year we published the frequently asked questions, which were questions that came out of this webinar. We are definitely working to produce the second version of that. And so for some of your questions that have not been answered today, our team is definitely putting this together to ensure that we're able to reflect the answers in the frequently asked question brochure that will be published soon. So Lizzie, over to you to wrap up the session for today.
Thank you so much, Dr. Wande. And once again, thank you to the panelists, and more special thank you to the participants who have joined in this session. It has really been a lovely 6 weeks of this series, and I would like to believe that we have learned a lot, especially with IPC program issues. For now, we are going to take a short break, and you will be advised that through the channels of when our next series is going to start. At this point of time, I would also like to remind you that the French sessions are still on Friday, and that the lectures for all this the series will be available on the ICANN and the Africa CDC websites, and we will also be having the Facebook live streaming. And then if you still have any questions that are still burning, please remember to send them to Susan, and also to from Africa CDC, and also to Anna from ICANN. Thank you so much, and enjoy the rest of the day. Thank you, and bye.
Thanks, Lacey. Thanks.
Thank you. Goodbye.
Have a good day.
Bye-bye. Thank you very much. Goodbye.
Thank you, Lizzie.
Bye. Thank you, Lizzie. Bye.
Bye.
And this mistake came out for today, they will break the first one to let you look dress. You see how the person struggles for quantity. Now, don't reply just now. You don't want to.
Something that did not reply to her.